They just confirmed my date.
We appreciate your participation. Very good. That's
I've only seen it from the outside because like that would be ages. One of those things that you go out of some. Because I'm the shaker. Even smaller. So I should assume I'm a bit. Also. I will. Sometimes it's usually. Well, I mean, on your face, maybe. Now. I don't know. We'll have to go to a meeting. What's this?
Which is not.
It's true. Recording and it's on. So it's.
I thought everyone was not 11 now, so we need.
Yeah, they're from somewhere else.
So look at this.
She went like, but if you want to, but if you're process getting bought, like, I guess I'm working like you. I don't know. I was gonna say, Clifton Park and the city of county, you hear me, I'm assuming you can, like, people.
You guys let us know who's in attendance at those sites.
I should run the poll. And put your camera on.
Call.
Hey, I ran the analytics. For a new student from the only goal, I think that.
I may have said if there's any inkling.
I was gonna say, it's almost. Movie space. Oh, was it?
And or let's see the.
Brian Terry and Chris Congaro at CPHM station.
Yeah, well, they just put it to me. They just turn their camera on.
I don't know if I've Steve Sell.
But I don't have to call their email, it's there. They're not, here we go.
Now we need.
Yeah, go to the park. It.
We need Columbia County.
After tonight's 3.
Three more.
That's it. Always done. Yeah. And then also.
Columbia County, could you please turn on your camera and give us an attendance?
And you still are gonna have to do separate EMS charts.
And who is 518-961-1419,
You're that far.
please?
That's Rich Salucci.
May or may not, so.
Hold on, watch out.
What's so?
Beth, can you hear us?
When I look at the matching, like, we're not.
Could we re-identify? We didn't have the volume turned up.
Beth, it's Steve in Columbia County. I'm here with PJ.
We're not
having
hearing
technical difficulties with the
Hold on,
video.
we're having a volume problem.
It's the same thing.
We're all the way up there.
On the camera.
We need to.
Should be able to hear you.
Columbia County.
Can you hear me now, Beth?
Okay.
Audio's on.
Is it?
I sent him a text.
Thumbs up. Somebody heard me turn it off.
Have Clifton's
God, can we just meet in person? Good God.
And we got to record it, right?
It's recording.
Is it?
Let's show it. I was gonna say, for the benefit of the folks who are joining virtually, we're just trying to work through a challenge with the folks from Columbia County. We're just pausing here.
Clifton Park, are you able to hear us?
So it's,
Yep, he gave you the thumbs up.
yeah, no, I saw that.
We can't hear them.
You can hear us if we unmute ourselves.
Go on to that. Go into the output device.
I guess they gotta vote.
We can hear you clearly.
Control V, sound up of Windows Control V. Windows.
I got it, I got it, I got it.
Okay.
See you when, right? That's not.
Which? What?
That's why we had to be here.
Well, I heartily recommended everybody show up. Still have 2 amongst us. You know, you can each.
And we can do more. I mean, that's, a side conversation. Like, if somebody said, hey, this particular area, you're a good spot to do one, you could do more. We're not to the point where you could be a single attendee at your house and put a sign out front, but I don't think that would pass. It'd be nice.
I had. Personally. It was. Oh, okay. Or says we. You can try it through your computer.
No, I just don't know. You have to go over and turn this volume over there off. Otherwise there'll be an echo.
Who else has it?
It's that, you got your
Microphone on it.
go.
If we get Columbia County on camera. Yeah, okay. Steve,
Yeah, we can hear you. We're just having technical difficulties.
okay,
This is probably gonna be the last time we do this virtually.
okay, and we can hear you, so we couldn't before, but now we can.
Beautiful.
All right. Well, 6:10, let's call the meeting to order and we begin with the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. And if we could just remain standing for a minute and recognize a passing of a caregiver, Kevin Robert, as many of you know, passed away while performing care. And we'll just again have a moment of silence. Thank you. Previous minutes are a recording and we didn't have a quorum, so nothing to approve. Excuse members, Maria Walker, Steve Retzlaff, and Alan Bell. And that'll bring us to Tim and the Executive Director's report.
Okay. Combined program agency contract payment for the first quarter of 2024, yes, 2024, July through September was received. $74,000, 74,908. Our second quarter deliverables and voucher have been submitted. Despite the fact that everything is almost a year overdue, we can only submit one at a time. They review it, approve it, we can submit another one. So the second quarter is in, third is ready to go, but we can't do anything until we get the thumbs up from the second. The EMS Awards Banquet will be held on Tuesday, November 18th, 6 p.m. at Delmar Bethlehem. They graciously agreed to host us one more time. Very appreciative of that to Steve and the gang over there. Training, our fall EMT class started September 13th. I'm working with JC now to plan the 2026 training schedule. And on a related note or semi-related note, our Remo course sponsorships have been renewed for another 2 years. I got notified and Beth got notified today from DOH, so we're good until June 2027. I have to thank JC for laying the groundwork and getting everything done on those. There won't be a budget discussion tonight. PJ and I decided we'll do it in October based on the vote and everything else we have to discuss tonight, but I'm going to propose a new line item in there. We have paramedic education coming up. We have recruitment and retention coming up. We need to think about recruitment and retention of our CICs here and maybe provide some incentive for those folks to stay on board and hopefully bring one or two new CICs into the Remo fold. I was thinking maybe some money set aside for perhaps Vital Signs or some other type of educational conference down the road. But I'll talk with Dave. I'll crunch some numbers with Dave. We'll talk with PJ, and hopefully next month you'll see some type of post line item for CIC recruitment and retention. The public hearing for the town of Knox for an operating certificate was held this past Thursday. There was no opposition, short and sweet, and Jim will speak more to that in sometime in the meeting. And that concludes my report. Thank you.
Any questions for Tim? Very good. Nothing under a chairperson's report. I don't believe we have anything for issue discussions. Would bring us to Dr. Daly for operational medical director report.
A bunch of reports. Couple of things that actually I'm going to start with. There have been a growing number of calls for physician response, and I think in a bunch of these cases they have been completely appropriate and have led to some significant outcome changes for the patients. The one thing that I would remind everybody is that the best way to call for a physician is actually not to call the physician, but to call the remote physician line at Albany Med and make the request there, where we will then be able to get the closest physician to you, as well as have the ability to deploy things like blood, additional drugs as necessary, a little bit more easily than trying to work backwards. It's really hard to get a phone call and then while running out the door, also call the charge nurse and try to figure out who you're going to get to go pick up that blood and all of those things all at the same time. So this all starts in a coordinated process right from the hospital it seems. So thank you for calling. We're more than happy to come. And yeah, so it's working out really well for a number of patients. And I think it's working out well for the paramedics and EMTs that are picking up all. That's really from an operational perspective the most important thing. I'll just go through some of the others as we go. I've got minutes being handed to me. And I don't know, I see. Rob, you gonna do REMAC, or do you want me to just talk about REMAC real quick?
You'll probably hit on everything, so go for it.
Yeah. What was that sense? I'm sorry, excuse me.
No, I was asking him a question.
Did you ask me a question? All good. Okay, so from one end to the other, from a quality improvement perspective, we have a schedule. We're working through strokes, knee trauma. We're gonna continue to do that on a rotating basis. Love to have people involved. It's been very robust discussions. Art's been great at bringing us things from the med. Getting some good flowers along the way, which is excellent. But bringing us cases where things haven't gone quite right and places where we can do things a little bit better. And getting the folks from really the stroke, STEMI and trauma services involved as well has also been very good. So bringing all that together has been really nice so far. We're getting, I think we're getting closer to regionalization of some of those processes with huge. From a REMAC perspective, things that became active discussions this time also trickled over into the CMAC meeting that was also this month. One of the things was iGel. It's actually a supraglottic airway project. It's not just an iGel project on a statewide basis. Gilman brought us a new tool that they've been using for a little while, which really looks like a nice device. It certainly has regional approval to be used if an agency wants to get involved. We are still waiting for the state to come out with a statewide policy on how the supraglottic project will move forward for basic life support providers. Which is kind of a shame because it really is completely built by the folks in the Hudson Valley and they did a really nice job with it. What was discussed with us at the CMAC is that the state is reticent to issue a policy because basic life support first response, like basic life support fire departments, they're staffed by EMTs. They actually have no regulatory framework over those providers and over those agents. I would argue the regulatory process over the providers because they certify them. But there is no regulatory process for the agencies themselves. So the state doesn't really know how to do this. It will be interesting to see what happens over the course of the next couple of months as this moves forward, particularly for the city of Cohoes, where they have a very robust BLSFR program staffed by EMTs. Dr. Ushkow would really like to move that forward up there, and he's going to work as hard as he can with the department in order to encourage them to move forward with BLSFR and this supraglottic project. Have to wait and see. The other project that is one of the things that's really near and dear to my heart, and we've been working very hard on. And thank you to the politicians that helped us get there, is blood for ground ambulances. We have a very robust group working here, coming up with a single procedure that will be instituted. We have some folks going after grant funding. We have the education being built. We're only waiting for regulations. We were told by the department that it looks like the regulations will be issued at some point in early 26 for comment, which then has a 90-day comment period. They then have to answer the comments, and then there's another 90-day comment period, and they said, well, we think we'll have regulations issued at the end of 26. That was exactly the look that I had on my face. I have subsequently heard from a couple of people that potentially that's why maybe a little bit more delayed than will actually occur. We'll have to just wait and see. We can't actually establish the rest of the policies we need to establish until we have the regulatory framework that we're trying to match the policy to. So we really do have to wait until some of this stuff is complete. But hopefully the grant funding will be in place by then. We'll have some good processes.
Seems like a common thing.
What's that?
Seems like a common thing.
A little bit. A little bit. The other thing, just in terms of interest, and particularly of interest to me because we just finished paper and sent it to publication this morning. We have come up with a policy for tourniquet conversion. that we will be issuing relatively soon. The idea is that people put tourniquets on all the time for hemorrhage control. They're ubiquitous right now. Every cop has at least 1 or 2 tourniquets on them, and they're using them anytime someone's bleeding from an extremity. But a tourniquet shouldn't be an endpoint, right? If we think about it, you're supposed to start with direct pressure dressings, and then go to a tourniquet as necessary, depending on what you've got. A police officer working in a dynamic environment, if we can engage them to take care of those immediate life threats, that's exactly what we want to endorse and thank them for doing. That gives us a chance to then take the next steps. The idea with the tourniquet conversion policy is going to be EMS arrives, evaluates the wound, and makes sure that the bleeding control measures that are being deployed for that patient are appropriate for the injury. They're the ones that the patient needs. So if the tourniquet's on, there isn't a need for that tourniquet because it doesn't appear to be an arterial injury, they can take that down in a gradual, reasonable fashion. If there starts to spurt, spin that windlass again, bring it back up. The idea here is make sure that the patient is getting the care that they need. When we looked at tourniquet deployment across 4 major trauma centers, we found about 30% of tourniquets were put on correct vessels, on correct situations where there was a vessel that was named, where someone had to go to the OR. The tourniquet conversion policy would be perfect for those other 30, for the other 70% of cases that may not have needed that tourniquet in the first place. Almost in concert with this, we had a case where we had a patient who had a tourniquet placed, but not actually tightened. Because the police officer showed up, it was a very significant injury. Police officer put a tourniquet on in case it was needed, it could be tight. It was a very reasonable thing to do. We then got a Remo call asking whether or not EMS could take that tourniquet off that had never actually been tightened in the first place. It was basically window dressing at that point. And it was there just in case it was necessary. It was thought, but it led to really interesting discussions on our part in terms of what the next steps are. I think very clearly, good education, thoughtful medical care, appropriate tourniquet conversion and removal when not necessary. So any other ideas about that, bring it to me offline. But I think this has significant opportunity to really help our patients. Any questions for me? TXA is now, we are pushing towards required for all agencies. Thanks, sir.
Are you going to issue an advisory on that as well?
Yes. With a reminder that the dose is 2 grams, not 1.
And you're gonna do re-education with it?
Hmm?
You're gonna put out re-education with it?
Actually, that re-education being written
Okay.
by someone other than me.
And that's even,
Which is awesome.
I was gonna say that's even better, but I didn't wanna.
No, it's okay. And trust me, I'm not taking it personally.
He hasn't looked at it. Well, I meant it, but last one I'll have to do. Give them some more food.
Oh, you're very kind. Thank you. Thank you.
So are you good with medical director, Remac Academic and QI?
Sure.
Excellent. PJ treasurers?
Okay, as Tim mentioned, we're kind of waiting to present the budget next month, but I just realized sitting here, we don't meet next month. So we may push something out by email if that's acceptable to everybody. We will have to share our budget with the ARMS as well because that program is combined now into one program grant. So we'll be sharing that as well. The last couple of years, we have waited until October to present the budget because we're trying to capture all the expenses through September to make sure that we've got everything calculated and what the expenditures were year to date. So we'll have to discuss that, but I believe if it's okay with the chairman and Tim, maybe we can push this out next month. Even if it's a preliminary budget for people to look at, it can still be approved in November.
Yeah, and we do,
We meet next month, PJ.
yeah, it's the Remax schedule. It seems weird that, but we do meet.
Okay, I can't keep track. I thought it was every other month.
Except for
Yeah, that would be too
August
easy.
is done in September. That's the,
Okay. Then I'll take back what I said. We'll have it for you next month.
With the
Okay.
vacation in the summer, it's the only way to get 6 meetings in for the year.
Yeah, okay, whatever. Okay, that's why I'm just the treasurer. Existing report, Tim sent it out to you. Nothing remarkable there. Expenses are right in line with our budgeted expenses. The only difference is obviously our revenue is way off, and that was due to the delay in the program grant. If you look at things closely, you'll notice that we had budgeted from the program grant about $355,000 in program grant. And to date, we've only received 186 from the state. And I believe Tim explained it too, that we cannot voucher for more than one quarter at a time. The second quarter voucher is in for last year, so they're kind of behind. But other than that, everything looks good, and we'll have a budget for you for next month.
Sounds good. Any questions for PJ? Sounds good. CON committee, we actually did meet over the summer. The anticipated application from Knox actually came in during that time frame. And as much as everybody would rather not meet during the summer, the time that it occurred in was near perfect because it allowed us to actually do all the steps that had to be done to have that for you for this evening. So sometimes things work out that way. So we'll cover that as we continue with the items on the agenda. Unless anybody has a question about that. No. Items from the DOH disciplinary actions that we've received. Bensonhurst Volunteer Ambulance Service in Brooklyn, New York State Agency Code 7193 had their ambulance operating certificate revoked effective 7/16/25 for violations of Part 800.2J and Public Health Section 30121B. Stephen Tanner of Warwick, New York State EMT number 430-642 surrendered his certification effective 6/20/25 for violations of Part 800.16A13. Course advisories, which is informational. Mohawk has an EMT Academy style course that starts September 13. Oh, yeah, sorry, October 13. No correspondence other than what's already been covered. From an executive committee, we did actually not meet. So that would bring us to Steve, Control of Finance.
No report on finance, other than money is flowing, and I imagine we'll put some back in savings, and we can look at reallocating those accounts when it gets there. But I think we have a few months of work to do before that happens.
Yep. And again, Steve, you're still on the floor for New York State EMS Council.
Yeah, not for lack of trying to get me off the state EMS Council and get even Steve or Carol on there. We have all collectively expressed our exacerbation to the Department of Health that my replacement has not yet been vetted. And will continue to do such since my term is up. But our last meeting was quite busy. I think Tim already mentioned, and the chair has on here, the Paramedic Education and Recruitment and Retention Committee. Each region that has a program agency contract will receive $35,000 a year, presumably for the next 4 years, to sponsor paramedic scholarships and for recruitment and retention initiatives. You have to spend it to get it. So we're lucky to be a region that has a little bit of money that can spend to get it back. And so I think now, I know we've talked about it at this meeting, but now it's real. Tim's gonna be vouchering for that. It's in his, we're one of, not all the regions have contracts. We are about half do, half don't. We're in there. That money is now available for us to use in this coming fiscal year. Big issues, Mike talked about the BLS IGEL and the BLS first responder regulation. I do think that
for first response agencies in the region. The Department of Health is likely to come up with some sort of voluntary credentialing or operating authority for the first response agencies, because when it came up that, gee, how do we let them do iGel? It also came up, how can a BLS first response agency be doing EpiPen or syringe epi or giving albuterol? And so now the concern has been widened a little bit. So my suspicion is that within, understanding how long it takes the state to do anything, within a year or two, we will probably see a way that a BLS first response agency can get themselves some sort of credential that allows them to do the BLS medication interventions that have already been, that our EMTs are doing right now on ambulances. So I think that will be worked its way through. The new equipment regulation that has been under development for several years got its final approval by the state EMS council. It now goes to the commissioner for sign off. I don't think there's any reason the commissioner won't. So once that is published, we will have 6 months to come into compliance of the equipment regulations for ambulances. And so that will, it's designed to make our lives simpler, not more complicated. But that doesn't mean there's not going to be a piece of equipment that any one agency may have not got. So as soon as that's published, I think probably, Tim, we should send out something to everybody. I think each agency really, you have to have whoever your equipment team is, read it from beginning to end and make sure there's just not something you do that's quirky that won't be in there. I don't think again, you got 6 months to come to compliance, and I don't think there's going to be real look to sort of nail people on it, but whatever planning needs to be done. The couple issues that are just going on around, I'd like to make sure people are aware of. We're still waiting for federal approval for the payment for treat and place. And the state EMS council has asked the Commissioner of Health to sort of try and accelerate the process. The governor signed that law in September 2024. Our state plan amendment to try to get federal permission was submitted on December 30th of 2024. So we're now 9 months waiting for basically an administrative checkoff from the federal government. That's what will allow us to get paid by the Medicaid program for diabetic wake-up calls, or for on-scene assessments and car accidents that result in RMAs. Considering that Medicaid pays us far less than it costs to do an ambulance run, but for a whole bunch of ambulance runs, it pays us zero. If we can go from zero to the $249.60 for a diabetic wake up, that certainly takes that average Medicaid revenue forward. So I think that's something that the council is continuing to work on. The law's been passed, we just need the permission to implement. For those of you that are in rural parts of our region, and I know that it is much bigger in Ames than perhaps in downtown here. But we have some rural parts of our region, Green and Columbia. There is a application period that is beginning right now, where the federal government is putting out a $50 billion pot of money over 5 years for rural health transformation as part of the recently passed tax Medicaid legislation. The state is going to be putting in an application, and the state health department has a group that is now meeting to try and decide what they want to do with that money. It's meant to help it's meant to help healthcare system become more sustainable and innovative. There is certainly interest in EMS in being involved. There's a technical advisory group. The state EMS council is meeting with the Department of Health to talk about funding for partnerships between hospitals and EMS agencies for mobile integrated healthcare in rural parts of our region. So I'll be going to that meeting this coming Friday. I'll keep people apprised of what happens here. But we've had fits and starts, and some people like doing mobile integrated healthcare and community paramedicine, and some people don't. We're trying to sort of stimulate, so it could be for a Columbia Memorial Hospital, or for example, being at the rural end, or for almost all the hospitals in Ames, they could partner with local EMS agencies on having EMS squads doing post-discharge work with people that went home from the hospital, or doing visits to keep people from going to the hospital, avoidable
avoidable, hospital emergency room visits. Mike, I don't think you talked about critical care techs when you were chatting, but,
They're
there's
not pertinent to the
and
Rainbow
they're
region.
not pertinent to this region, but I thought everyone would be interested in knowing is that the critical care designation is trying to make a comeback in some parts of the state, and it's going to be a item of discussion, I think, at the state councils for the next couple of months about how that works out. And one of the things that may come out of it is the possibility of changes in the scope of the AEMT level of care and bringing it up a little bit higher over the next couple of years. So if you're interested in the AEMT level of care, that possibly happen. Other interesting things, a lot of work, there's gonna be some advisories coming out on the use of, you look like you wanna say something.
No, you're suggesting there might be changes in the scope of practice for advanced EMTs. The reality is actually that would require legislative change. In order to add the things that they would want to add.
Put on the list. All the
Absolutely.
things that have to get done, right? There is some work being done on the use of AI in EMS and especially in charting. A reminder for everybody, feeding your PCRs data into the AI models, is not necessarily HIPAA compliant, because remember, AI models are not only taking the data you give them and crunching it, they're sucking it in. So, be careful about that. You realize that you have to make sure that you're doing AI compliant way. There continues to be just discussion about hospital wait times. And, it seems like things are improving statewide. There were only 2 hospitals in the state in the second quarter that had offload delays of more than 45 minutes, more than 10% of the time. Now that doesn't change the world if you're the EMT or paramedic standing in the ER for that 45 minutes or longer. Again, the best way for us to know about it is to bring issues to the region, bring issues to the region. If you see that there's unequal activity happening anyplace. I know my agency, we're starting to have much less concern about this on a daily basis, but I think the only way we can elevate it up to the state EMS council is if people actually tell us about the experiences they're having, positive or negative. The last thing to mention is Vital Signs Conference is coming up November 11th through 15th in Syracuse. It's really becoming a growing conference and a lot of really cool things happening this year. If you have not been part of it over the last few years, a growing number of pre-conference sessions. For example, there's going to be a TECC class this year, which is something that's a new feature. There is a field training officer class this year in the pre-conferences. There's a supervisor's leadership training course in the pre-conferences. They're having the EMS research forum. They're having the Vital Signs Games, which I guess is a skills competition. So a real effort being made to raise the profile of the conference back to what it maybe once was. So if you're interested in taking a look at it, registration is now open, and the EMS Council meets again in December, and maybe I'll be there or maybe Carol. We'll see.
Steve, did you want to talk about the National Registry reciprocity problem and the independent submission of CMEs?
Yeah, the National Registry is having some real problems with their new computer system that they're using. And that has made it very difficult for the state to validate somebody's test score. So right now you can take the National Registry test or you can take the New York State test. Now, if you take the National Registry test currently, the state can't give you your card because they can't validate your score. It's taking between 45 and 90 days to get that validation. And they have the registry has not been able to tell us when this is going to be fixed. So if you've got a course sponsor, you've got people that are going to take the National Registry exam, they just have to keep in mind that there could be a delay in them getting their New York State certifications. And we don't know when that's going to end. I think the registry is probably running around with their hair on fire trying to fix this. New York State is pressuring them to fix it. But, for the people that are taking their state exams, their exams in the next couple months, I think that should be a factor for a course instructor to make sure people know about. If you do the New York State test, you should be able to, turn it around very quickly.
And we are very fortunate in that we don't absolutely depend on National Registry. There are states.
There are states only now that are completely FUBAR, because that's the only test they have. All right, and there was one more thing we're supposed to talk about.
Independent, the portal for independent recertifications exists.
Right, so now, if you are a EMT that is not aligned with an agency and you wish to recertify, there's actually a policy statement in the portal that will allow you to do it. Which I think was passed in, it was, the enabling rules happened like
July 24th.
But 2 years ago, they said they were gonna do it. It took 2 years to actually get it done. So that's another path to recertification for people. And we were reminded that the Department of Health, Bureau of VMS, Division of VMS does not accept paper for just about anything anymore. Everything's going through the portals. And just keep that in mind as you're doing things like your agency update, where you have to, renew your operating cert. Agencies are mailing things in, and they're turning them around and mailing them back and saying you will not accept paper. So transition period on that is basically over. It's use the portal or.
In fact, they created a new portal for CME maintenance, like CME plans, MOUs, things like that. That's also on the education page.
So exciting stuff. Thanks.
Also, St. Peter's, I don't know if you guys saw it, they put out a new practice for the wait times, reporting of wait times that came out today.
Oh, you mean in the hospital?
In the hospital.
Like you click on a code?
No, they have a whole system and I can get it out for people. They send it out to the agencies, but it's in this pile of stuff here. There's a process they want you to follow, a notification chain to elevate the issue after 30 minutes. I could tell there's a 30-minute, 45-minute, 60-minute progression for, so that just came out this afternoon.
They never have a process of how to escalate things internally, so depending on the shift is how they dealt with it, so they're really driven to try to make it.
Yeah, I'm sure it's somewhere in your emails. It just went out like this afternoon.
Very good. Any questions for Steve?
There's one. Clifton Park asked, has the governor signed the property tax cap exemption?
The governor has not signed the property tax exemption bill or the county EMS planning bill. They have not yet been forwarded to the governor by the legislature. So we still don't know when that will happen, and we still don't know if she is going to sign it. So if you want it signed, you should have your town officials and yourself continue weighing in with the governor's office, with your state senators, assembly members, saying why it's important to your community that the bill gets signed. It is the conventional wisdom is in a upcoming gubernatorial election where affordability is going to be one of the key drivers, right? Who's making New York affordable for people to live in. There is fear that piercing the tax cap and allowing exemptions can be exploited to attack incumbents for being fiscally irresponsible. So there's pressure in one direction to not sign it, but there's also the pressure of the New York Association of Towns and to sign it. And the New York Association of Counties is kind of like sitting on the fence, because some of the counties want it, some of the counties don't really want it. So this is one where if it matters to you, please weigh in. I know the New York State Volunteer Ambulance Rescue Association has all the levers we have to try and get it signed. And I think Onion has stayed neutral on this one.
Sounds good. Barbara, nurse.
We met on the 11th, September 11th. Really, we talked about some old business that 12 lead EKGs. Consensus of the group was to have 12 lead EKGs sent primarily through Pulsera. The only hospital area not on Pulsera United, the paid version, is the Albany Med Health System. I think all St. Peter's, and Ellis are on the paid version. At least right now, Ellis with the paid version, the gatekeeper of the ED, which most of the Pulseras have always had that a nurse or ED attending kind of would look at an EKG and then activate the cath lab. Ellis's STEMIs are actually going directly to the cardiac interventionalists. And being, so EMS is essentially activating the cath lab. So. We talked about transfer delays, specifically Glens Falls, said that they were continuing to have delays out. Although Carol Grant brought up, and I saw something from JP that, there has been discussion about, transfers for ambulance. Although Glens Falls and Saratoga are seeing delays, there's also delays in both those hospitals following Mohawk. So subsequently, there's going to be some discussion about that as well. We invited Margaretville Hospital into we pulled them into our regional nurses committee. For some of you who don't know, that's kind of south of here. They also have, which I kind of was new to me. I knew they had a hospital run ambulance. They actually have two hospital run ambulances. They have one on that's 24/7, and they try to keep a second one for transfers, but they have delays like even with their own service as well. And that was significant since I guess there was I'm not really sure, but there was some issue with AMR in Delaware County. And right now, Empress is the primary EMS response to their hospital. Albany Med got their DNB comprehensive stroke certification, and Glens Falls Hospital was going through their primary stroke certification survey. It should have been this week.
It was approved.
Okay. Great. St. Peter's was saying how that they are having, specifically the stroke, we're having issues pulling metrics from EMS documentation. So there was some discussion about EMS leadership to write rules for the information that they were looking for so that they could get the metrics a little bit easier, which led to a discussion about EMS not putting in vital signs, stroke scales in dedicated areas of Pulsera. And there was something that went out about that. Carol had said at Mohawk, there was something that went out. We've seen an increase in compliance with vital signs. And just so people know, I mean, a set of vital signs could trigger somebody, a trauma patient that is not a level trauma patient to, level 1 trauma patient. So it is significant, and people are looking at it. The part of the new business that came up, and it was the only last thing, was blood transfusions, and it was the transportation of blood that's occurring currently. That Julie, specifically from Saratoga Hospital, there is I did not put the form numbers on here. It's like 5210 and something else that are supposed to be returned to the blood banks. And the blood, specifically Saratoga, is not seeing that paperwork returned to the blood bank. In a couple places where I talked to, forgot who I think, Carol, did we have a discussion on the phone with someone?
Yeah. Adam.
Yeah, and so one of the things that I had looked at for blood bank at Saratoga is I tried to pull up a couple patients that were like within the last couple of days that I knew had blood come in, and they weren't attached to the chart either. But it seems like in talking to Mohawk and talking to a couple other people, those forms are specifically to the users that are using Zoll EMS charts. That paperwork is not attached. Like when you close the PCR, it's attached later on in the process. So, what I explained to Julia at Bloodlink is that I could give her access to EMS charts to go look at attachments. But for the hospital it's hard enough right now. We're chasing rabbits every day to get PCRs in a timely manner. on patients, whether they're STEMI trauma or strokes. But for now to add the blood bank, paperwork in there, I don't think hospitals should have to do that. That's just my general opinion. But just so you know that there's a paperwork issue with that, and I don't know how that will come over to ground.
Well, what they're attempting to do with the regulations is actually tie the ambulance transfusion service and the intra-facility transport of blood to the ground EMS initiation of transfusion, and hopefully have one set of regulations that governs the whole thing. Because it's really apples and oranges almost. The only thing that's the same is the red stuff you're putting into the patient. The accounting and how that paperwork needs to flow will be a challenge to see how they do that. But, you know, if you pick up a patient at a hospital and there's paperwork that you're given, that they say this needs to be returned to my blood bank, they should return it to the blood bank. That's a
Well, like,
I think we're
EMS
supposed
in the
to
case
fax
of-
it back, aren't we?
you know.
in Mohawk's case, I
I
think.
think we're
Adam-
supposed to, I think he said we're supposed to drop off at the one hospital, then fax back to the other
Other
hospital. I think that's. what
It's
we're
just to
supposed
close the loop
Yeah.
on that unit of blood.
Yeah.
That unit of blood part isn't an issue if you're the one that initiated it. Because if you initiated the transfusion, it's gonna stay with you, right?
Yeah. So that was, you know, that was it. We're getting better attendance with the nurses committee, and it involves Ames region as well as the Remo region. Our next meeting is November 13th at 1 o'clock. And if you have any agenda items, you can send it to either me or Beth. We'd love to have you there. So.
I think when I talked to Samantha, Sam. At St. Peter's, they still wanted us to send the EKGs both ways.
Okay.
Through LifeNet and through the
And she wasn't at the meeting,
because
so.
they're still getting their interventional cardiologists still get the LifeNet alerts.
Yeah.
So that's the way their cancel system applied. So, and then she wanted the people to get in the habit of doing it through Pulsar, so when they officially make the big switch, it kind of got that in.
The only thing I'll say, just for the hospitals on our end, just from our providers, it is very confusing for them to say St. Peter's wants it this way.
We know, that's why we wanted to get a standardized.
We are like, we've told our people, send it through Pulsera. If you get a chance, then send it through LifeNet, but we're not sending it both just because.
So that's fine.
It's-
I'm just saying that's what she wanted.
Saying send it both ways.
No, just because we want them to get in the habit of doing Pulsera, get it attached in the right way.
Yeah, that's why she told us to do Pulsera, but then she also said the only way their interventionalists get notified is through LifeNet, so.
Laura Smith reported at the Schenectady County meeting that it is in fact LifeNet for St. Peter's. They are not getting Pulsera EKG. So it still has to go through LifeNet.
The thing is, right, and this is the silly part, when we first moved towards adding Pulsera a couple years ago. The goal was, right, consistency, everybody would do it the exact same way. We would move towards Pulsera United right from the start. And, you know. For whatever reasons, that Art's a lot closer to this decision making than I am. It's just not happening within the Albany Med Health System. I don't understand why increased communication and cleaner communication channels just don't make sense. But we have a lot of challenges communicating between departments. Each department that I contact through the emergency department has a different pathway. Some want to be texted and not called. Some want to be called and not text. Some just want us to put in the consult, but not to call them because they'll call us. It's challenging, and there is no consistency because each one has a different workflow style. So, I mean, Pulsera is very clearly a much better answer for us all to have the exact same idea, but we haven't even really figured out how to do physician consultations on Pulsera yet either. And that will be very helpful when we do that because we can convert to video as well, right? I've got somebody trying to figure out if it's a stroke, right? Okay, show me. Let's look at it together. Let's do the exam together. We can do that on Pulsera with video. It's a great tool. Really like for us to buy the tool.
Say, Art has probably had enough.
The only other thing that came up, it was part of the PI. And it was talked about by trauma in the nurses committee, is that there are emails that are generated from the trauma program that come to me, that come out to different providers. The trauma registrar is changed to, it used to be like an ESO product, Trauma One. I'm not sure what the iterations fall out. It's now called Juniper, if you guys want to look it up. But there is AI technology built into the trauma registry. So realize EMS reports are going into Epic. Trauma registry is pulling out of Epic sometimes your reports. AI is making it, it's not a human who is triggering a flag, like a QA flag. It is a QI that's being generated by AI technology. Just like in some of the EHR software, like if you have somebody that has fever or respiratory rate over 20 and a white count over whatever, have you started your sepsis protocol, 30 cc per kilogram IV fluid. So AI, I know Image Trend has got it in it now. I know Zoll is working on it. We are about to step our foot into that, whatever you may think we were stepping into.
You're stepping into it, right? You're stepping. Yeah.
Sounds good. If nothing more from Art, BJ, MCI.
No report at this time.
Very good. Thank you, BJ. Membership remains open. Nominating.
No report.
No report. Very good. Awards. Nothing under awards. Anybody from Albany County?
There's on board.
No report. Columbia County?
Nothing significant to report.
Greene County? Rensselaer County?
Ben Bornhorst. Just a few updates, and I know it's some of the news is a little old. Town of Poston killed, contracted with Sand Lake Ambulance, so they now have dedicated ambulance service. The town of Brunswick did pass for for money to be allocated for a dedicated ambulance service. I believe starting next year. There's still more to come on that, on what the process is going to be for them seeking out coverage for next year. So we're starting to fill some of the gaps in Rensselaer County, and hopefully the system can continue to expand after these two towns in the middle of the county have dedicated ambulance service. That's all I have for right now.
Want to add to Rensselaer County, we just had 2 EMT classes that began. And for those of you who've been around this table for a few years, on October 5th, we're holding our county memorial service for EMS, fire, and police. And among those being honored will be Kevin, Robert, and Evan Ice.
Very nice. Saratoga County?
No report from Saratoga County.
Sounds good. Schenectady County?
The only thing I have to really report is we had our annual meeting last week on Monday. Schenectady County Ambulance went in service last month. I can't remember the exact day. They've already covered 25 calls, which is proving that there is a need for them. They're already reducing kind of stress on the other agencies. But other than that, I don't have much more to report. Chief, you have anything?
Sounds good. So under new business, obviously there was a CON action that came before Remo. The report of the hearing officer was, I believe you sent that out to everybody. Yeah. Yeah. So it time compressed. That actually just happened last week. But the report of the hearing officer was essentially that the hearing officer's recommendation was that the permanent operating authority be issued So the vote tonight would be a seconded motion from the CON committee to essentially allow that to occur, that the town of Knox would have a permanent operating authority. Unless there's a question on that, it is a roll call vote, so we can have Carol begin that.
Okay, I'm gonna call the people that are eligible to vote because they're either here or at the 2 remote sites. Okay, does that make sense? So PJ Keeler,
In favor.
Steve Meehan,
In favor.
okay, Kathy Allen,
In favor.
Brian Terry,
In favor.
Chris Conjero,
In favor.
okay, Shannon Smith.
In favor.
Okay. Gotta get used to him.
She signs in.
It's easy to.
Well, I signed in the name.
She signed in the name she was given. We
Yeah.
actually changed it mid-meeting. We changed the name in the middle of the meeting. Dr. Daly, Steve Roll.
In favor.
Great. Okay, my list. Murray Croft in favor. Okay. Me in favor. Lynn Kane in favor. Jim Stairs.
In favor.
Dale Lingenfelter.
In favor.
Charles Welch. Okay. Adam Zink.
In favor.
Art Bro.
In favor.
I think that's it.
Yeah.
He's not at a remote site or here. So. 16 in favor, no no's and no abstentions, so it passes.
Just, I think it was mentioned just in comments, up until this point, but one of the new communities that's, important to, hit the ground running, for lack of a better description, is related to the paramedic education, which is a scholarship related thing, and then a recoupment retention, component of that. So, I think Tim will probably reach out to folks and just ask if you're interested in becoming part of that. And then from that interest, we'll probably create some kind of a virtual meeting to get some input and some thoughts on how we want to move forward as it relates to providing this hopefully a wonderful opportunity, and one that comes with timely reimbursement from the state, which I think is a concern on everybody's part with the amount of time it takes to get paid. And we'll be spending obviously a significant amount of money to do that. No, go ahead.
Can I suggest that we invite the directors of the 2 paramedic programs that feed our region to maybe designate someone from their team to be on this committee? Because if we're going to be giving scholarships, those scholarships are probably going to somebody that's going to Hudson Valley or somebody who's going to Copelskill. So makes sense that, those guys send us somebody that's familiar with how they do things to make it a little smoother, and might keep us from coming up with something that then they go, oh, well, that doesn't really work for me.
Yeah, no, that makes a ton of sense. I mean, unless you're gonna say that, Howard was in attendance at the retreat, so I'm sure he's gonna be part of it or interested.
He's
in
already
being part of
signed
it.
on
Yeah.
from the Aram side, and we'd like to get it so that both regions
I was gonna speak to that.
combine.
Yeah,
Go
we
ahead,
need to
Tim.
consider a joint venture here and bring our Aram's counterparts into this too. So we develop these committees, Remo/Arams, have people from both sides of the table on it. So.
That makes a lot of sense. One set of rules.
Makes my life easier.
Yeah.
And then just the other handout that you guys have, or that I think was sent to everybody who's there remotely, is just a breakdown of proposed committees, what they would do, and how they would fit into our operations moving forward. So again, thanks to Beth for being the creator of this as we were doing this live at the retreat. But the goal is to, I guess, in many respects, mirror what the state looks at and how they look at it. So at least we're looking at the same things, and
there isn't duplication or we aren't missing out on something. So, go ahead.
I'm sorry, I think Carol had a few thoughts too to toss out.
No, I was just thinking that, and that this summarizes a lot of it, is that let's look at some of the committees we already have and see, are they really committees we need to have? Or, I mean, some of them you can see once a year, they don't have many functions. Or are there committees that could expand their function? Like we have, like we've been dealing with at the state level, that all hazard preparedness, or we're actually changing over to emergency preparedness, something we should probably look at for the region, because they're finding with some of these events, these snowstorms that they've been having, that year after year, they go through the same things and nothing changes. There's no coordination of services. Nobody knows who has what for resources. And we should probably look to at getting regionally, are we gonna have a consensus on when do we stop responding to some of these things? When you have 12 feet of snow out there, are you really going to go to that alpha call? But if you can come to a kind of regional consensus as to, it's not just this one agency that's not going, it's like, as a region, no, we're not doing, it doesn't make sense. It's not good for our people. So expand that, and this looks like it's going to fall under a systems committee, which is a good idea, and put some of that stuff together. So I just want to look at some of the committees we have. I think they're getting a little outdated. So this will help pull that together, it looks like, but I think we should look at that. And the way this with their committees, which is why I brought up several many meetings ago, was that they're the workhorses of the county. So it's not like you meet once and just give one report. They meet a lot behind the scenes and do a lot of legwork and a lot of the heavy lifting, and then you bring it back to the council and you say, okay, this is what we've done for our assignment. So a lot of work actually gets done behind the scenes.
Most committees
More
meet
focused.
once a month, and every once in a while, there's so much to be done that we meet once every 2 weeks.
Right. That's something that we did for some, talking about the paramedic, sponsorship and the recruiting retention, things like that. I would realize to be more of this stuff.
Sounds good. So I would say check your emails and there'll be more stuff this coming month regarding that. And obviously the goal is to have people express an interest and serve on these committees so that we can, move whatever it is forward. Just, I guess, anecdotally, as it relates to items on the floor or going back to the recruitment and retention thing, I'll just throw this out because it's something that's come to mind every time we talk about recruitment and retention. There is an unusual behind the scenes kind of person that works in pathology. For those of you old enough to have ever watched Quincy, which was a show about a medical examiner. Somebody is. Art probably saw it. He's old enough first. Yeah. Well,
Art saw him on network.
did he? Could have been on network. Anyway, but a TV show about a medical examiner. If you paid attention, there was a guy who worked hand in hand with Dr. Quincy, who was a medical examiner, a physician. There was a guy named Sam that was a character, and Sam was a histotechnologist. Pretty bizarre. Histo means tissue in Latin. Cobleskill actually has, for decades, had one of the few histotechnology programs in the state of New York. It's a 2-year degree, and you complete that and graduate as a licensed histotechnologist in the state of New York. It would be rare for you to go to any hospital in this region where they actually have that level of pathology and not find a Cobleskill graduate. So as odd as recruitment and retention may sound, it actually does work. Cobleskill has been at the Cobleskill Fair, as an example, for decades, touting this very unusual program, but it does work. So I think there's some great hope that we will be able to get folks interested in EMS as a career and hopefully fill some of the vacancies that are out there. The other thing I was going to bring up, and it was from a conversation both in person and messaging back and forth with Mike McAvoy as a result of Kevin's unfortunate death. The public safety, police and fire, if you have a line of duty death, there's a benefit that's just part of the system that employs these folks governmentally. That does not exist in an EMS component unless you happen to be connected to government. So if you're just a, you know, a freestanding agency, there's nothing to support you. To the credit of the region, and I just looked a little bit ago, the GoFundMe actually raised in excess of $27,000 for that process there. So it's not that a method isn't out there, and thank God we don't have that many line of duty deaths. But the conversation I had with Mike, and he said he hadn't personally done it, but I would encourage folks to do this, is whoever does your benefits for your agency, health insurance benefits, it's probably a component of their insurance offerings that they could give you a company sponsored death benefit for your employees or staff members. And I'm guessing that the amount of money that you would contribute annually would be quite small for something, you know, to the tune of $25,000 or $50,000. It's, yeah, I mean, you know, again, hopefully that doesn't happen that often. You know, it's terrible to talk about it, but I guess if you don't prepare for it, you know, it'll probably happen more often. And as it relates to my conversation as a component of police and fire, Mike has said that they've already attempted to try and get a whatever, a hand into that police and fire retirement system or the system that would pay that. That'll never happen. That's just, you know, my opinion. It's never going to work. So I'm just throwing that out. If you guys want to investigate that and potentially have it as a something for your agency. So
Cool. Paper by the-
do you? Is it expensive? Just out of curiosity? No, I can't imagine it would be.
Of course, employees, yeah, we have about 30 employees.
Yeah. Yeah, and that would be wonderful. Obviously, it's a tragedy no matter what public service component you're involved in to you know, lose your life at a young age when you shouldn't be in that position.
Would that cover the volunteers as well, Kathy?
It could. Actually, I believe, we don't have that many riding volunteers anymore, but yes, we are those students.
Well, that
So-
would certainly be helpful.
Yeah, I think it's a great idea, and I think providing some leadership on what sort of opportunities there are around that sort of a benefit is certainly something that's for the region. That's one of the things we talked about at the retreat, right? Is what value does the region have, right? We have career flyers sitting here. We have municipal employees. We have a whole lot of people from independent, not-for-profit organizations. We have commercial. The more leadership we can provide to the people that don't necessarily have that already built in, that's really important. The other thing that we've talked about around this table before, going back all the way to Chairman Robert, I believe, right, is the idea that this group would have a committee, and it's not a, you know, standing committee group of people that's going to get involved, whatever structure it had, specifically to deal with line of duty death and significant injury in order to support those smaller agencies. I can tell you that I thought LifeNet did a spectacular job with Kevin's death in terms of leadership through the whole thing. McAvoy and the folks up in Saratoga did a great job. Hudson Valley stuff. Everybody that was involved there really, I thought they did an excellent job. But if that wasn't as robust an organization, it would have been a really real challenge in order to honor him the way that they did. So I still suggest very strongly to this group that we put a team together in order to make sure that we can respond to those types of critical incidents and support our brothers and sisters.
Yeah. And I would echo what you said. I think the event in Copac was also well handled by, you know, partner agencies who you know, took up the slack and did what they had to do. But yeah, I just throw myself a note. We need to have that as a committee.
That'd be a perfect ad hoc committee. Develop it, put it together, and then your work's done. Doesn't go on.
Yep. Any other items from the floor?
Believe that there is a
document out of
There's a
Pennsylvania.
document
Out of
there,
Pennsylvania.
line of duty death
Mhm.
guide that has been put together by the National EMS Memorial Foundation. And we could start with that. And Mike, it was Kevin, I think, that actually brought that up. I believe, and shame on me, but I don't remember his name. But it was a gentleman who was driving.
Jerry Stalker.
Thank you.
Castleton.
Thank you, it was Castleton, it was Jerry, whose last action on this earth was stepping on the brake as he was driving.
Pulling over on I-90 in the middle of traffic with a critical patient in the back.
Yep.
Last thing he did was save the EMT and the patient.
Yep. Yep. Thank you. Thank you for remembering.
It was my
Thank you.
dependent.
Yeah.
Yeah, thanks for that information, Steve. I'm aware of the one in Pennsylvania, which is quite exhaustive, but I'll take a look at that too. Because that,
So who do you,
The National EMS Memorial Foundation. They're the group that holds the National EMS Memorial Service and is congressionally chartered to build a national EMS memorial in Washington, DC. Someday, maybe.
good. Anything else from the floor?
There will be a journal club this Thursday at the Tech building. That my fellows are putting together. I have for information on that and come join us. The one thing we can't do is push out the articles because that would be a copyright violation, unfortunately. So we can't pick the people we can. And if you RSVP to us, then we can share the articles we're gonna be working on. You can't just push them out broadly, fortunately.
what's the
There's titles.
topic?
You can look them up, you can pull them yourself, but we can't download them from the library and send them out.
I believe it's on Ross, isn't it? It's on Ross.
I believe so.
I've got a question for
Yeah, go ahead.
Doc. I'm just wondering if you've heard anything further regarding the mental health law changes from earlier in August.
The next REMAC meeting, we are bringing folks from a couple of different mental health agencies in to help discuss them with us. We still have nothing formal from the Department of Health. But the 941 is is sort of a cleaner delineation of what the requirements are. But the part that's challenging for us is, and will be transported by EMS.
Yeah.
It's in there too. And that guidance is going out to law enforcement and hasn't come out to us yet.
Gotcha. Thank you.
Department is aware of it. I made sure.
Several of us did.
Mm.
So hopefully we will have some more information on that, Steve, at some point in terms of guidance from what the state thinks we should do.
Appreciate it.
Ben has a question too. Go ahead, Ben.
Yeah, Ben Bornhorst, Rensselaer County. Just one of the things that earlier discussion when we were talking about Pulsera, one of the things coming back from the hospitals are looking for vital signs. One of the things that I'm hearing from some of the providers is there's a big discrepancy between the hospital systems and some of the hospitals within the same system on what they do with the information when they receive it. Such as like Albany Med, the patient's essentially pre-regged with the information that the demographics we provide to them before we get to the hospital. In St. Peter's Health Partners at St. Peter's, the registration clerks or whatever their official title is have access to the Pulsera information that we send, and they at least have it in front of them. They confirm the information with us and register the patient. But then at Samaritan Hospital, the registration people have no access to the Pulsera information at all, and it's all brand new and a surprise when we show up. So I was just looking for, maybe we or the nursing committee provide some sort of guidance or a way to make this sound across the board for all the hospital systems so that it doesn't seem like the information that we are providing to the hospitals is only giving certain people a heads up and not others, and we could kind of speed up the registration process with the information we're providing to them.
I'll make sure, Ben, that I send you an invitation for the nurses committee.
I'd love
I'm
to
writing it
attend
down
if
right
I
now.
could.
The other thing too is that St. Peter's will be holding a leadership meeting with the leaders of ambulance agencies at some point over the course of the next couple weeks. That might be a good topic for you to bring up at that. I think Sam would be quite willing to hear you talk about that as well. Remember, these are all still independent hospitals, so they're gonna make decisions that are gonna be best for their own workflow as well. We're walking slowly into using this technology. Little trust goes a long way too. You register somebody wrong, there's a significant amount of work that's gotta be done to fix it on the backside. So there's a whole lot of different elements that go into that. But I think that, to your point, when we can make this as seamless as possible and as smooth, let's make it work.
Yeah, I mean, there's definitely been some improvements in the system. Like there was a point where St. Peter's, if somebody had altered mental status, and even if we had brought them from a facility, they'd be registering them as John Doe's because the patient couldn't confirm their social security number. They've at least changed that, and now when they're coming from a facility and we have paperwork packet to prove that this person is in fact not Jane Doe, they're registering them as that patient. So there has been improvements, but I just like to see some, and the like a lot of the providers that I've talked to, just kind of a standard across the board of how they're dealing with the information that we're providing them with.
Sounds good. If there is nothing else, our next meeting will be October 27th. And with that, I'll accept.
One quick thing.
Yep, go ahead.
I just want to recognize Beth for everybody. Beth has been appointed the chairperson of the
Quality metrics.
Quality Metrics. It used to call it Quality, now it's Quality Metrics Committee of the State EMS Council, which puts her in a leadership position. Basically, what we do at our quality metrics, so we don't call it quality metrics, we call it
Process improvement.
what we do at our process improvement has been recognized, but now Beth is the sort of leader of marshaling all of them in the state into one cohesive quality group framework. So it's quite, I think it's probably one of the most important committees and it's quite an accomplishment. So
Thank you, Steve. For someone who doesn't speak quality, it's been a straight uphill learning curve. And I'm dragging Leah with me.
and the thing about being a committee chair is you're on the executive committee, which is you get to be in the room when all the fights happen. Where there are no cameras. Right. Yes.
Well, congratulations.
Thank you.
All right, nothing else? Motion to adjourn?
Motion to adjourn.
By Lynn, second by Steve. All in favor? We're out of here.
Thank you for your, when you're gonna come